Hi, my name is Francisco Sanchez Leon. I work as a medical director of Nova Visión Laser Center in Mexico City, and I've been working with Medifocus and Kettering for the last 15 years. I also work as a consultant for this company. In the following presentation, we'll discuss our early experience using the Kettering AS.
The following presentation will introduce the new Kettering AS or Kettering Asymmetric. This is the most newer addition to the intracorneal segments family produced by Medifocus. The important difference of Kettering AS is the progressive effect of this segment, and this implant is distinguished by having a variable thickness. As an introduction of the corneoplasty concept, we need to remember that these techniques allow the surgeon to remodel the cornea, avoiding invasive procedures such as lamellar transplants or penetrating keratoplasty. And the corneoplastic objectives are to improve the optics, improve corneal topography, improve the refraction, and the general optical performance. From my point of view, Medifocus is a truly vision in evolution company. A timeline of segment release is as follows. The SI5 160 degrees. I've been using it for treating myopia since the year 2001. The SI5 90 degrees and 120 degrees were designed to treat astigmatism and were released in the year 2004. The SI5 210 degrees was specifically designed to treat myopia with low astigmatism and was released in the year 2005. The SI6 90 degrees, 120 degrees, 150 degrees, 210 degrees were released in the year 2008. The SI6 340 degrees, designed specifically for treating nipple cone, was released in the year 2012. And finally, the second generation Kettering and Kettering AS both were released last year. Last year, second generation Kettering came out. These implants are made of two segments joined by several bridges. These rings comes with diopter power with the aim to create an ideal curvature. For better understanding of the mechanism of action of Kettering AS, we need to remember two basic rules that apply to any type of intracorneal ring. The smaller the diameter, the higher the correction. And thicker segments provide higher correction and flattening effect on the cornea. This slide shows the features of Kettering AS. This segment has an optical zone of 5 millimeters, an arc of 160 degrees. The basement measures 600 microns. It comes with a triangular shape. It has a progressive thickness, and we have two models, the 150 microns to 200 microns, and the 200 microns to 300 microns. The thickness increase direction can be clockwise or counterclockwise, and the shape of the segment seems an arrow, indicating the direction of the thickness progression, clockwise or anti-clockwise. This is an example of Kettering AS with progressive thickness from 200 to 300 microns clockwise. And this is an example of Kettering AS 200 microns to 300 microns with anti-clockwise progressive thickness. The progressive thickness of Kettering AS produces a progressive flattening effect, allowing better customization treatment according each patient needs. A progressive effect achievement is observed in accordance with thickness increase. In terms of Kettering AS models, we have the SI5 160 degrees, 150 microns to 250 microns, which I recommend for cases with lower than 5 diopters of spherical equivalent, and they come in clockwise and anti-clockwise fashion. And then we have the SI5 160 degrees, 200 microns to 300 microns, which I use for patients with higher of 5 diopters of spherical equivalent, and they come in clockwise and anti-clockwise fashion. Well, when Kettering AS is indicated, we recommend Kettering AS for patients with asymmetric topographic phenotypes and appearance, such as the snowman, duck, or cross-eyed phenotypes appearance. The best results has been observed in patients with spherical equivalent lower than 6 diopters, cylinder up to 4 diopters, in patients with compound myopic astigmatism, and of course we need 400 microns of higher. This slide shows the 3 topographic phenotypes categories for Kettering AS indication: snowman, duck, and cross-eyed keratoconus phenotype appearance. For those of you interested to go in detail, I recommend you the Instituto Fernández Vega classification from Oviedo, Spain, and keratoconus phenotypes for intracorneal ring segments refractive anterior-phakic correction. You can find it online. In this Orscan quad map, we analyzed the snowman phenotype topography. In this case, the refractive astigmatism is direct or inverse, and they present a horizontal flat axis usually, and high vertical comma as well. In this snowman phenotype appearance, the corneal abnormality is paracentral and inferiorly, and relatively orthogonal. The intracorneal ring segment choice is difficult because the chromatic axis will increase the astigmatism. This Orscan quad map analyzes the duck phenotype topography. The refractive astigmatism in these cases is direct or oblique. The flat axis is located less than 45 degrees away from the topographic abnormality, and in these cases we can find non-coincident comma. The cross-eyed phenotype is the third example where Kettering AS is useful. This Orscan quad map corresponds to a cross-eyed phenotype topography. The refractive astigmatism in these cases is direct or oblique. The flattest axis is located more than 45 degrees away from the topographic abnormality, and in these cases, coincident comma is observed. For surgical planning, we suggest to use the guidelines of Kettering nomogram based on corneal topography asymmetry classification system in accordance to reference meridian. As we know, type 1, 100% of the steepest area is located on one side of the reference meridian. The type 2, the distribution of a steep area is approximately 20% and 80%. Type 3, the distribution of the steep area is approximately 40% and 60%, and type 4, the distribution of the steep area is even, 50% each side. One message to take home is the more asymmetric corneal topography, the more asymmetrical implant should be. And finally, we can combine these concepts with the wide variety of Kettering available segments. My suggested femtosecond laser parameters are depth 70% of the corneal thickness at 5 mm optical zone, inner diameter 4.8 mm, outer diameter 5.3 mm, length height 1 mm, cut thickness 1 micron, and the incision needs to be made at the steepest meridian. This video corresponds to a snow phenotype keratoconus case. We use a pair Keraring AS SI5 160 degrees, 200 microns to 300 microns. First, the clockwise or horario segment was inserted, followed by the anti-clockwise or anti-horario segment. As you can observe, a tight insertion is created by the femtosecond laser in order to achieve an appropriate corneoplasty effect. This topography analysis corresponds to the previous snowman phenotype case. The preparative refraction was -775, -6 axis 30 degrees. Postoperative refraction achieved was plano, -3/4 axis 5 degrees. The incision was created at the steepest meridian at 130 degrees. In this case, we use a pair of Keraring AS SI5 200 microns to 300 microns, clockwise and anti-clockwise segments. A flattening effect of 5 diopters and a quarter was observed. The astigmatism was reduced from -4 1/4 to -175. This is a pentacam sagittal curvature differential map from the previous case. The K2 shows 5.6 diopters reduction change, and some areas inferiorly, a reduction of more than 7 diopters was achieved. This is a very rare inverted snowman phenotype topography, where major abnormality is located superiorly. In this case, the rule changes in order to locate the thicker part of the segment superiorly. For surgical planning, we use anti-clockwise where clockwise was indicated at the temporal segment and vice versa, clockwise at the anti-clockwise on nasal sector. This is an axial corner topography analysis result. The surgical planning considered an inverted pair of Keraring AS SI5 160 degrees, 200 microns to 300 microns segments. Preparative refraction was -475, -175, axis 50, and we achieved a postoperative refraction of +1, -1, axis 120 degrees. And as you can observe, the postoperative corneal topography improvement is notable. The pentacam sagittal curvature differential map from the previous case shows at the K2 a reduction of 5.6 diopters change, and some areas superiorly a reduction of more than 8 diopters was achieved. The following example combines Kettering AS with a standard Kettering SI5 160 degrees. Preparatively, uncorrected distance visual acuity improved from count fingers to 2040 postoperatively at 6 months follow-up. The best corrected visual acuity improved from 2080 to 2030. Prepared refraction improved from minus 350, minus 7, axis 30 to plus a half, minus 1, axis 180 degrees. The surgical plan used in this case included at SI5 160 degrees, Kettering AS 150 microns to 250 microns anti-clockwise at the temporal side, and the use of SI5, the standard Kettering 160 degrees, 250 microns at the nasal side. This is an axial corneal topography analysis result from the previous case. The surgical plan considered in this case was the use of a combination of a Kettering AS SI5 160 degrees, 150 to 250 anti-clockwise segment inserted at the temporal side in combination with a standard Kettering SI5 160 degrees, 200 microns inserted at the nasal side. From minus 3 1/4 and minus 7 1/4 axis 30, preparatively, we achieve an improvement to plus 75, minus 75, axis 170. The topographic cylinder was reduced from minus 6 to 1 1/4. The corneal power was reduced more than 6 diopters, and postoperatively, the corneal topography improvement is notable. This is the pentagon sagittal curvature differential map from the previous case. The K2 shows 4.9 diopters reduction change, and important topography changes are observed at the temporal area where the thicker end of the segment was inserted. This case corresponds to a dog phenotype topography in a post-LASIK ectasia case. The surgical plan for this case includes the insertion of only one segment, Kettering AS SI5 160 degrees anti-clockwise, 150 microns to 250 microns inferiorly. The preparative refraction was minus 2 1/4, minus 350, axis 35, and the postoperative refraction achieved was plus 50, minus 50, axis 75. The topographic cylinder was reduced from minus 3 to minus 1 1/4, and the corneal power was reduced by 3 1/4 diopters. This is the pentacam sagittal curvature differential map from the previous case. The astigmatism was reduced from 2.8 to 1/2. K2 shows a reduction of astigmatism of 4.6 diopters. And important topography changes are observed at the temporal area where the thicker end of the Kettering AS segment was inserted with corneal flattening effect above 5.5 diopters. In conclusions, the Kettering AS represents a new tool for irregular corneas with asymmetric or irregular astigmatism. Kettering AS accomplishes the aim of corneoplastic concept because it improves uncorrected distant visual acuity, best corrected visual acuity, refraction, and corneal topography in asymmetric keratoconus phenotypes. Finally, This new generation of intracorneal segments showed efficacy and safety for the treatment of asymmetric keratoconus in patterns like snowman, dog, or croissant phenotypes. Thank you very much for your attention.
Thank you very much for your attention. And if you have any questions or comments, we are open to interact with you.